Hello, I'm Dr. Mark Anderson from Case Western. I'm a third-year resident there. The title is aforementioned, Heller versus Poem, Should Obesity Influence a Surgeon's Decision? Myself and Dr. Sippy have nothing to disclose. Dr. Jeff Marks, who's the senior author on this project, is a consultant for Olympus and Boston Scientific. So in the interest of not being redundant, I will be very brief with our background of achalasia, as Dr. Ali was very comprehensive. So achalasia, failure of relaxation of the LES, symptoms can progress to aspiration, malnutrition, and even malignancy. It's a relatively rare disease. However, we are seeing it in our clinic pretty frequently. Etiology can range from idiopathic to autoimmune disorders such as amyloidosis and sarcoidosis. Diagnosis is made with a high-resolution manometry, and treatment, as previously discussed, can be with medications, endoscopic interventions such as Botox, pneumatic dilation, and then finally Heller or POEM. POEM has shown pretty good success rates comparable to laparoscopic Heller myotomy, as evidenced by the projects listed here at the bottom. Adverse events, most specifically, can include perforation, incomplete myotomy, but what will be the focus of my talk here is GERD is the most common late adverse event, ranging from 20 to 57% according to different accounts. In a meta-analysis by Dr. Schlattman last March in the Annals of Surgery, they demonstrated that laparoscopic Heller myotomy, while allowing for concurrent fundoplication, can actually show decreased GERD symptoms, decreased acid exposure on pH Bravo testing, and also decreased erosive esophagitis. GERD is not a benign disease. It's very common, as stated, up to 15% of the patient population is currently on a PPI costing about $10 billion to the US yearly. Diagnosis is largely clinical. However, the gold standard is pH monitoring with a Demeester score of 14.7. Disease course is not benign. It can lead to esophagitis, Barrett's esophagus, and an increasing incidence of adenocarcinoma. The treatment is wide-ranging from lifestyle changes to surgery. And finally, risk factors, the main one I'm going to focus on is obesity. So here's my slide on the obesity epidemic. Obesity is increasing. Ohio just got edged out of the top 10. They come in at number 11 for the obesity rates. However, the Ohio, or at least the Cleveland hospital population, boasts an obesity percentage rate of about 41%. And it's been shown that an increase in just 3.5 BMI units it leads to a threefold increase in the risk of GERD. So then it follows that since obesity is a risk factor for GERD, and POEM has been shown to lead to possibly iatrogenic pathologic reflux, are obese patients at an increased risk of developing this reflux due to our procedures that we're providing them? And if that is the case, should a patient's BMI impact our decision to offer POEM versus obesity? And we attempted to at least preliminarily answer that question. So data collection was done by a retrospective review of a prospectively maintained database from January 2011 to present. All patients undergoing POEM for achalasia are entered into this database, and it's at a single institution, UH in Cleveland. Some outcomes defined for the purpose of this study. Preoperative reflux was defined as having been on a PPI. Not all patients underwent Bravo testing preoperatively. Post-op reflux here is defined as a positive post-op Bravo study. And finally, post-POEM or iatrogenic reflux is defined as patients who had not been on a PPI previously but had a positive post-op Bravo score. So inclusion criteria are patients who underwent POEM for achalasia. Patients who underwent POEM for other indications were not included in the study. The patients had to have completed a post-POEM Bravo study at their 6-month follow-up. And those who did not were obviously not included in the study. We ended up with 36 patients, 58% of them female. The average age was 60, with a median BMI of 28. Now, achalasia is usually thought of as a disease of skinnier, malnourished patients, but we had patients up to a BMI of 42. Here are our results. Preoperative reflux, as anticipated, was higher in obese patients. and then 64% of our patients were on PPIs. Our postoperative reflux, was, according to our Bravo studies, was actually, there's no statistical significance, 43 versus 41%. And finally, iatrogenic reflux, there is no statistical significant difference between the obese category, BMI of 30 and above, and the non-obese. Some secondary data points that we discovered in mining through our data is that many of these patients who were on a PPI preoperatively ended up not having objective physiologic reflux on their post-POEM Bravo study. 4 of these patients had hiatal hernias, which could be confounding variables. However, half were obese and half not. Finally, all 6 of the obese patients who had positive post-POEM Bravo studies were already on a PPI. And then finally, weight gain. So 36 patients in the study, they gained an average of 1.31 BMI points over a mean 21-month follow-up period. This was more pronounced in our underweight or normal weight patients. There we go. So some conclusions. Achalasia and obesity, as evidenced by our patient population, are not mutually exclusive disease processes, and since POEM has been shown to increase the incidence of reflux, and obesity is a well-documented risk factor, this doesn't necessarily confer a higher risk of iatrogenic reflux in these obese patients. Future investigations are obviously needed here, with hopefully more consistent preoperative and postoperative measurements of GERD, longer-term follow-up with long-term Bravo studies, and also looking at objective symptoms in PPI use as well. Thank you.